Hey guys, let's finish up our acute psychosis tutorial. Okay, so yesterday we said that just to recap, we said that yesterday anyone guys can come in with acute psychosis, whether they've got a primary psychotic disorder or whether they've got a primary psychiatric disorder, or whether they don't have any of those. Like we said, anyone can become psychotic. Anyone can just start presenting with signs and symptoms of psychosis, which we said they are delusions, hallucinations, disorganized speech, disorganized behavior, right? So we said someone who presents with this, that person is psychotic. That person is psychotic. So now, a person who's psychotic, they can be psychotic because they've got a primary underlying psychotic disorder, such as schizo. Guys, I want you to get this, especially the students. It's very, very important. They might become they might present acutely psychotic because they've got schizophrenia, because they've got schizophrenia form, or because they've got brief psychotic disorder, or because they've got schizoaffective disorder. Those are primary psychotic disorders. You can also have someone who present with acute psychosis and they've got a primary psychiatric disorder, not necessarily a psychotic disorder, like someone who's got bipolar mood disorder. Now, bipolar mood disorder, what makes them to be psychotic? Remember, psychosis is not part of bipolar. So the minute they've got bipolar and they've got psychotic features, then it means they've got bipolar with psychotic features. That's a specifier. Like I've been saying, psychotic features, né? Or they might be having major depressive disorder with psychotic features. These are the ones that I'm aware of at this point. I mean, guys, anyone can have psychotic features at any given point. At any day, anyone can have. It's not impossible to have an anxiety disorder with psychotic features, even though it's not very common, but it's not impossible to have that. But what I wanted to make it understand is that your thinking should be along these lines. If they do not have okay, let me say, so the other secondary causes, like we said, it can be substances, and we spoke about substances a bit, and then medication, digoxin, things like that, even some antibiotics. You know, the one of the well-known medication that causes psychiatric illnesses is the ARV, efavirenz. Substances, medication, and general medical condition. Ne? So, what I want to explain here is that when someone comes in with psychosis, even if you know, or even if their history says that they are known to be having any of these, you still have got to investigate them for this and this, because like I said yesterday, that it's not impossible to have schizophrenia and present with acute psychosis from a substance. So now it means you've got two things overlapping. Or you've got schizophrenia or brief psychotic disorder, but you've got maybe some folate deficiency or B12 deficiency or whatever the case may be. So which means that whenever we see patients who are psychotic, the most important thing, it's not exciting to jump to here. It's not exciting. We should pay attention to is these things. They are very, very important because this will actually kill the patient. A patient who is psychotic, who has got these conditions, they will not necessarily die from this. They've been having this, they've been working with this, it's okay. But what will kill them, especially a medical condition that has not been diagnosed. So we shouldn't be always jumping, even if we know that, okay, this patient's got schizophrenia, but we should still do the investigations so that we can say, okay, even in this instance, their psychosis now is still due to their schizophrenia, and we have not picked up anything there. Because if they've got something there and you don't address it, that can be disastrous. Okay. Okay. Another thing that I wanted to explain yesterday is I just forgot to. I mentioned it, but I didn't explain it. I said that we're in the Eastern Cape, and neurocystic psychosis is very prevalent here. Many patients who are epileptic, let me say there are many patients who are epileptic because of NCC. So when these patients come with psychosis, we need to do NCC ELISA. If you go to other parts of the country when you do NCC, they might even laugh at you that you are doing NCC because it's not very prevalent, very common in their setting. So yeah, to complete your wake up. Okay. So now this patient comes in with psychosis. What do we do? A patient who's psychotic is not necessarily. Let me write this again. Let's say delusions, hallucinations, disorganized speech, disorganized behavior. And we said that in order for us to say someone has got acute psychosis, they must have one of the four, at least minimum one of these four symptoms. Patients who are psychotic, the ones that are very dangerous are these ones, depending what is their disorganized behavior. If they are threatening people, they are destroying property, they are assaulting people, then these ones are the ones that you really need to knock them out. Someone who's just as good disorganized speech, who's just talking, is irritating to the patients that are sitting. It's embarrassing for the family to have someone always talking, things that are not making sense. Now they are sitting there waiting for the doctor, and attention is drawn to them because they are with a family member who's talking things that are not making sense. So, but these people, when they've got just disorganized speech, they're not harmless. I mean, they're not harmful. Sorry, they're not harmful. They're just talking and talking. Some of them would be singing, and so they're not harmful. So these ones you don't really need to go aggressive on them, but these ones you need to go aggressive on them. I'll explain now. Someone who's got hallucinations, even these ones, they're normally not doing anything. But someone who's got delusions, and it depends which hallucinations are they having. Someone's got delusions, if they're not commanding, they are unlikely to act to the delusion, right? Okay. So now, these ones, the point I'm trying to drive in is that these ones you really, really need to know to be decisive when it comes to managing them. And remember, someone can be psychotic and not aggressive, but you can have aggression. We are going to talk about how do you manage an aggressive patient on another video. So let's say this one is not aggressive, it's just psychotic. So what do you do? What you want to do, and you are the casualty officer, you are the GP, this patient will come to you, not to a psychiatrist. The psychiatrist will only come later when you call them and you have stabilized the patient and all of that. A patient who's got disorganized behavior, but they are not aggressive, you might not need to really restrain them. There are two ways of restraining. Of restraining a patient. There is physical, and then there's biological. A patient who's busy beating up people, who's busy threatening people, who's busy just extremes of agitation, extremes of aggression and all that, that patient will need to be managed as an aggressive patient, which we are going to talk about. But physical restraint is just simply having people tie this patient. Most of the patients will come in already handcuffed or tied with a rope and all of that from the community or by the police. So that's a physical restraint. You can tie them. We are going to talk about this. But biological, which is this is drugs. This is what we do in the hospital. We can do this, but the thing is this: when a patient comes in, they are under a physical restraint. When the drugs have kicked in, these things should be removed. They should be removed, but do not remove the restraint before you have given the biological, the drugs. Otherwise, you're going to have a situation in the hospital where you have to run for your life. Okay, so I want to talk about this. I'm going to leave someone who's got disorganized behavior for an aggressive patient. How do we manage an aggressive patient? But let's say the patient doesn't have any of this, is having maybe this, and is just sitting there talking to himself, all of that. So what you do there is you give your benzodiazepine. There are three that I'm aware that are being used, depending where you are. Where we are, we use lorazepam, short acting. Lorazepam, some places use midazolam. I think in Pretoria they were using midazolam. When you are really out of options, you can go to diazepam, but it's not recommended that much. These are your go-to drugs: lorazepam, midazolam, diazepam. So these are not antipsychotics. They're just there to sedate the patient, knock them out, make them to sleep. And you also add, this is a protocol that we follow, we add promethazine. Which is just sedation as well. Now, the thing is, once you have given these drugs, this patient will be knocked out. Everyone is going to get rest now. The family can stop having to pay a lot of attention on them. Even everyone around will be safer now. But the thing is, we have not given them an antipsychotic. So when they wake up, they are likely to continue with their behavior. So this is when now you need to give your haloperidol. Which is usually, no, I don't want to bother with doses here, but promethazine is 25 to 50 milligrams. If a person is an elderly, you can just settle with 25 milligrams. And then lorazepam, diazepam is, you can give 5, you can give 10 milligrams. And then the one that we use, we only, for old people, we give, not old, like someone who's more than 18 years, give 4 milligrams. IM, even IV you can give, but the IV dose is lower. It's 0.5 to 1 milligrams. That's the IV dose, but the IM is 4. If the patient is less than 18 years, we give between 1 and 2 milligrams. That's lorazepam. I'll check this up. We don't really use this. We always have this though. And there are times we don't even have any benzodiazepine in the hospital. We only have promethazine and haloperidol. Haloperidol is 5 or 10 milligrams. So this is the only antipsychotic that you can give. Not that you can give, né? In a case of an acute setting, you can give that. So haloperidol is a typical antipsychotic. It's a first generation antipsychotic. We're going to talk about those as well. Another thing that you can give, if a patient is maybe just talking, or you can also give your atypical, which is your risperidone, is a drug of choice, which is oral. If this patient does take oral, they don't mind. Even haloperidol you can give oral. Even lorazepam you can give oral. But it depends on the situation. You can go for oral or IM or IV, depending what is happening, what is the situation, how aggressive is the patient, how calm is the patient. If you don't really need to knock them out very fast, you can just go for oral. You can give oral drugs. And if you don't have haloperidol at all, before they sleep, you can just give them risperidone, which is 3 milligrams. We usually start with a high dose, but risperidone can be 1 to 3 milligrams. But we usually start with a high dose, risperidone. Or risperidone. So guys, so you have done all of this. And then now you have done all of this. Now you start taking your bloods, the one that we mentioned earlier on. You wait for your bloods, and then you discuss the patient with the psychiatrist. The patient now is going to wake up much better. Now you've got your blood results. You talk to a psychiatrist, and then now it's going to be their job to find out if your blood results are all normal. It's going to be their job to find out what is the cause of the psychosis. They can go on deep with their history and do a collateral history as well. But as a casualty officer, it's not really your portion. Okay, so guys, we are done with this. Okay, the only thing we're going to talk about now, we're going to talk about how do you manage an aggressive patient. Thank you.